I mean, prevention is key if we're going to be able to meet the burden that we currently have on our health systems. People are getting older, they're getting multi-morbid, we're finding ways of keeping people alive for longer.
Hi David, thank you so much for doing this and for sharing, for being available for this conversation. We truly appreciate your time. So, as I understand, David, you're working as head of operations for NHS, and for our listeners who are outside of UK, if you can explain NHS, its structure, I think that would be a great starting point for our conversation.
Sure. Okay. So I work within NHS Wales, which is the National Health Service for Wales, which is part of the United Kingdom. That incorporates conventional hospital care as well as primary and community care, and within it, then we have some specialist organisations, things like the ambulance service, and organisations that support education and digital transformation, as well as day-to-day delivery. My current role, I'm acting as a deputy director within a team for value transformation, and within that, we're looking to support organisations within NHS Wales known as health boards and trusts to deliver clinical transformation, looking particularly at virtual care or virtual enabled technological care.
Makes sense. Thank you so much for these details. So, as I understand, NHS Wales is a very big publicly funded healthcare system overall.
Correct.
And in your understanding, what's the population count that it is serving at the moment? I assume it must be a big number in terms of population it is providing care.
Yep. So Wales has a population of roughly 3.1 million people. We deliver that through 7 health boards, which cover the entire geographical area. And we have then NHS trusts. So we have one Welsh Ambulance Trust, we have a Public Health Wales Trust, and we have a Velindre NHS Trust, which is a specialist cancer organisation. And then we have something known as Digital Health and Care Wales, which supports all of our digital and data infrastructure, and organisation known as Health Education and Improvement Wales, which again does what it says on the tin, which is supports the professional development of our staff across NHS Wales.
Makes sense. Thank you. So it's a big ecosystem. I mean,
Yes.
It's quite a good number of people you are serving, and the entities that are part of this are also, I would say, they are quite few. So, in your opinion, what are the typical operational challenges that you or your team encounters in order to ensure the smooth working of this big system?
I think included in those challenges are too many priorities. So that then becomes the fact that there aren't any priorities because everything's a priority. We also have, just to challenge that very thing itself, each local health board has its own nuances. It has its own local priorities. So there is a degree of autonomy. So even though we are a national health service, there is a degree of autonomy, which means what might be the top priority for one organisation may be the second, third or fourth priority for another. We also have an approach which is people like to do things with their own adaptations. So although Wales likes to work on the basis of adopt something once for Wales, that isn't always straightforward. So we have to take into account local nuances, local differences in process, also definitions. So you might call a team the same thing, but it might actually not deliver exactly the same things equally. So therefore, why you might expect that the medical assessment unit might be called the same thing, but they may not do exactly the same thing, which can then cause interpretation of challenges. So you may think that it's straightforward and linear if we ask all seven directorates of medicine to do X, doesn't mean that they will.
Right, right. And it's a unique challenge, I can assume, because typically what happens is in an organization like yourself, there is, I mean, if we talk about smaller areas or geographies, there is typically mandate from government or from authorities, and that mandate helps professionals like yourself execute things flawlessly or seamlessly. But it seems like that on your end, the challenge is also the difference of priorities on different ends. So, how much you are empowered as part of your role to dictate some of that, or is it that you have to 100% respect the priorities of each stakeholder?
Yeah, so none of it really works in a linear fashion. There's very few absolute mandates where people will be told you must do the following. Wales is trying to move to something where we focus on the outcomes, so that so long as you get the same outcomes, how you get there doesn't necessarily have to be the same. So warranted variation is acceptable. Unwarranted variation isn't acceptable, but that's a sort of a secondary issue afterwards. So in other words, if I take a good example, we would like everybody to have the same opportunity for, let's say, revascularization after a heart attack. That might have to be delivered through different pathways depending on where you present. So, for example, you may not have a primary angioplasty suite locally. You may have to travel for that. So therefore, the local process may look different compared to if you had your heart attack outside of a specialist revascularization centre, which means you might get taken by one ambulance directly to the catheter lab and revascularized. So we're looking at outcomes. We're also trying to push more around patient-reported outcomes. So what really matters? And beneath that then is getting the outcome, and the resource utilization in order to get that outcome becomes a next level question. So we might get the same outcomes, but it costs us 3 times as much in one setting than another. So we have to look at whether or not that's good money spent, because of, you avoid emissions further down the route. So it's a very complex situation. And I think that's just healthcare generally. You're looking after human beings with human beings. I don't think it gets much more complex.
So, David, how much you are depending on data and analytics for creating better visibility, or for example, I'm sure if you have good data and reporting in place, maybe the future actions you do, or future roadmap you create helps you use the optimal path.
In an ideal world, that would be the case. However, we don't necessarily have all the data that matters being counted, collected, analysed, because I think we're still at a very, I would say, an embryonic stage. We're still trying to figure out, and I don't just mean NHS Wales, I think generally people haven't been recording the type of data that you may want to know and therefore use to inform your decision making. So we may not have been collecting patient-reported outcomes in a methodical, consistent, standardised manner for a long enough period for that data to become meaningful. We might say that in order to make the best decision, we might need 50 data items, but we've only currently got 23 of those items, and therefore we have to make an informed decision. So I think it's not just having the data available, we've got to agree what it is that we want available. Is it easily available? And is it an active collection process or is it passive? And what I mean by that is if I'm a clinician and I want to get certain information about a patient, how many systems do I need to go in? How much
Right.
times do I, how many times do I have to enter the same routine data? So do I have to regularly enter the NHS number in order to access the next set of data? Or do the systems go, yep, it is David Heyburn who's asking for this information, therefore you don't have to keep putting in loads of passwords? Whereas actually what I'd like to see is something which I don't have to press a button for something to happen. It's passively pulling everything into one space for me to collect it all. I don't have to go actively looking on data entry for me to understand it. We're nowhere near that yet.
So, is there any focus or any priority for creating a centralized
Yes.
repository of patient records, for example, like HIEs?
Yeah. So Wales is looking at having um, a national data repository, and the idea is that patient data will be moved into that repository. That will come through from local clinical repositories. So all of your national audit data will feed into there. And in an ideal world, you would hopefully have a situation whereby, let's say that I'm a patient with chronic kidney disease. I've also had revascularization. I've got diabetes. My data has gone into a variety of clinical audits. At the moment, they all transfer in silos. So my
Right.
data might be used in the renal registry. It might be used in the MINAP data for cardiac, for MIs. It might go into diabetes, but they don't talk to each other. So nobody will be able to go, oh, look, that's David's data for his diabetes. That's for his cardiac. That's for his chronic kidney disease. Oh, and actually he's got gastro problems and he's got this. It doesn't happen as that, but that's the intention, is that we will get there.
Right. You are right. I think a lot of healthcare systems are working in silos at the moment, not only in UK, but I mean in majority of the world, and that is really is one of the things that, if improved, will make a huge impact on overall quality. So I want to ask you one thing, because you deal with a big spectrum of systems, and based on my experience working with US healthcare and US entities, there is a shift in the mindset of healthcare professionals in US, and of course from government level, that they are slowly transitioning to value-based healthcare service instead of pay per visit. So what they are trying to get to is that a provider should get paid, or a clinic or doctor should get paid once they are able to recover patient permanently. So in that attempt, what they are bringing in is a lot of additional supporting systems. For example, one thing is social determinant of health. Social determinant of health is becoming more and more popular in US, because they have analyzed that patients who sometimes does not have access to basic necessities, and they end up becoming burden on the healthcare system. And if they address that social need, it first of all is a cost effective way. Secondary, it reduces the burden on the healthcare systems. Something like that is on the cards for NHS as well.
Yeah, absolutely. I mean, prevention is key if we're going to be able to meet the burden that we currently have on our health systems. People are getting older, they're getting multimorbid, we're finding ways of keeping people alive for longer, they're getting frailer, and so they consume a lot more resource. We also have to recognise that medicine is typically the number one intervention that we provide at the moment. So, whatever your condition, we've probably got a tablet for that. You that doesn't necessarily make much difference in the long term when you think about, well, why should I be giving somebody antibiotics, steroids, etc., because they've developed COPD, when we've made it relatively easy for them to smoke. We also have allowed them to live in a accommodation which is it's cold, it's damp, and therefore and also because of their educational attainment, they've not done very well from an economic point of view. So we understand all of those things play into people's health far more than actually typical hospital health systems. When we look back at human history, good nutrition, clean water, good sewage, antibiotics have taken an exercise, have taken care of most of the things that we can do. But we seem to worry too much around the small interventions that
Right.
we do otherwise.
Right. It makes sense. So there is a lot of work happening in US that they are creating systems that are connecting hospitals with social agencies. So doctor can refer a patient right away to a social agency, and in this way they are creating a whole person care experience for them, and it is really helping them improve the overall health of the population. So David, I want to ask you about the workforce challenge that healthcare have been facing for a while. Do you also feel that there is a shortage of experienced, trained healthcare professionals, or you feel that this is a challenge that UK has overcome effectively?
I think we do have. We are really struggling with our workforce. We have a slightly different arrangement in the UK and Wales. So we don't have a produce too many workforce, and therefore we have market forces. We don't necessarily produce enough workforce, and therefore we've got stress in the system. We have seen that we've got an aging workforce, and actually when people retire, because of some of the issues we have around our pension system at the moment, we're seeing people retire earlier than they probably want to because there's no benefit for them to stay on. And so we're creating this perfect storm of vacancies. We're also having a situation where less people are wanting to join the health system. So we also are trying to challenge a medic first approach. So it always used to be about, do we have enough doctors? But actually we have a multi-professional solution. So we're trying to grow that as an approach and upskill our workforce. But I fear that we're not going to do very well for a while. I think we're going through a really difficult period as we go, transitionary period, where we're losing people, not recruiting enough, not training enough.
Of course, I think the one big area which I think will need a lot of time for us if we simply start talking about is burnout in healthcare professionals as well. I think the shortage of workforce is also resulting in burnout for professionals.
Yes.
But uh, I think again, if we talk about a little bit about AI, what is your thought process on that? If is there a possibility that AI can, first of all, help us meet this growing need of more and more workforce, and can it help with reducing the burnout? For example, I think if we talk about clinicians or doctors, one thing they hate is doing the documentation post surgery or post treatment,
Yeah.
and I think bringing in AI in workflows like that, is it a good idea? What's your take on that?
I think it is going to be a good idea, and I think AI will be part of the solution. Um, I personally already use some AI in the work that I do, and it helps streamline some processes. It helps crystallize thinking. Um, I it does make me more efficient and more productive. I think that there will be ceilings to that depending on each profession. I also think that we need to be mindful that many people who want to go into healthcare want to actually be involved with patients. They want to get their hands on, they want to have personal interaction. And so
Right.
we need to make sure that we don't necessarily lose that. And so I'd want to see AI and other such technology release our human time so that it does take up some of the things that you're talking about, the documentation side of things. So how does it do that in a passive way? So there's lots of ambient voice technology that would do a consultation, for example. I think those sorts of things, so long as they become reliable and consistent, I think they're excellent ideas.
Yeah, yeah, makes sense. Thank you. And I do have one final question for you. And in your experience, what is one thing, if you have, there may be many, but what is that one thing that rest of the world can learn from NHS?
From NHS Wales, I think that we called it prudent healthcare. We've rebadged it as value-based healthcare. And I think that that is fundamental in talking and listening to the patient and understanding what matters to them most. And really understanding something simple as what difference will this make? And if I give you a really good example, we do lots of our arthroplasties. We replace people's knees, and if I wanted to have my knee replacement done, but I was told that you wouldn't be able to do what you really enjoy, i.e., kneeling down and playing with your grandchildren, would I still want to have my knee replacement? Because essentially, you replace one pain with a different pain, but you get mobility with it. If I'm not getting that, then why would I want to do it? And I think it's those types of conversations we need to have more of. Linked to that, so I'm going to be a bit cheeky. My second thing is we need to talk about good death more than we do.
Yeah.
So I would say that good death means good living. So we need to do more of that.
Yeah.
Value-based healthcare is Wales. NHS Wales is shout out. Let's know what matters and do something about it.
Sounds great. Thank you so much, David. I really loved our conversation, and I really am looking forward to having a episode 2 of this, if you are open to that, and because we have a lot of topics that we can dive more into. But I really appreciate you taking our time today.